Every 66 seconds, another American is diagnosed with dementia. By the time this video ends, roughly 20 more families will have heard those words. For a meaningful number of them, the real cause was never age at all. It was a bottle sitting on the bathroom shelf, one they were told was perfectly safe. I'm Dr. James Revealio. In years of clinical practice, I've watched this same story unfold more times than I can count. Someone who was sharp their entire life starts losing the thread. Names slip, appointments get missed. The drive home they've made 1,000 times suddenly feels unfamiliar. And everyone around them, including sometimes the person themselves, calls it just getting old. Often, it isn't age at all. It's a medication. One that almost nobody thinks to question because a doctor prescribed it and a pharmacy filled it without a second thought. Here is what a growing body of research keeps showing us. Certain ordinary, everyday medications can measurably affect memory and learning, sometimes within a single year of regular use. And most people taking them have no idea it's happening. Today, I'm walking you through 9 medications most closely linked to memory and cognitive decline in older adults, counting down from the ones that quietly get overlooked to the one I consider the most concerning of all. Watch for number 3 especially. It's handed out for something that sounds completely harmless, and the mechanism behind it may surprise you. Before we start, tell me in the comments how old you are and which of these medications, if any, you currently take. I read every comment, and it genuinely shapes what topics we cover next on this channel. One important note before we begin. Nothing in this video is a reason to stop any medication on your own. Every single recommendation here starts and ends with the same instruction: talk to your doctor or pharmacist first. What this video gives you is the right questions to ask them. Let's start at number 9, and don't let the low spot on this list fool you, because this one sits in almost every medicine cabinet in America. Number 9, Diphenhydramine. You know it by its drugstore name, Benadryl. It's the little pink pill people reach for to fall asleep, calm an allergy, or take the edge off a cold. It costs a few dollars, sits on an open shelf next to the toothpaste, and because nobody needs a prescription for it, most people assume it must be gentle. Inside the brain, it behaves quite differently. Benadryl belongs to a class of drugs called anticholinergics. That's a technical term for a simple idea. These drugs block a brain chemical called acetylcholine. Acetylcholine is the messenger your brain relies on to form new memories and to stay alert throughout the day. As we age, the brain naturally produces less of it and leans more heavily on whatever it has left. A drug that blocks this chemical lands far harder on a 75-year-old brain than on a 25-year-old one. The structure that takes the brunt of this is the hippocampus, the small, seahorse-shaped region where new memories are formed before being filed away for long-term storage. In practice, I've seen patients take a nightly antihistamine for years and slowly lose their mental sharpness, never once connecting the fog to the pink pill on the nightstand. The research backs this up. A landmark study led by Dr. Shelley Gray at the University of Washington, published in JAMA Internal Medicine in 2015, followed more than 3,400 older adults for an average of 7 years. It found that people with the highest cumulative use of strong anticholinergic medications, including sedating antihistamines like diphenhydramine, had a 54% higher risk of developing dementia compared with those who used little or none. And what troubled the researchers most was how invisible this risk was to the very people carrying it. Many had used these products for years as simple over-the-counter sleep aids. Here's what to do. Read the label on anything you take to sleep and anything marketed as PM, nighttime, or allergy relief, because those products are very often just diphenhydramine wearing a different name. If allergies are the issue, newer generation antihistamines like loratadine, Claritin, or cetirizine, Zyrtec, cross into the brain far less than Benadryl does and are generally considered safer choices for regular long-term use. Never stop a medication on your own. Bring this list to your doctor. But stop assuming that over-the-counter automatically means safe for your memory. A simple habit worth building tonight. Go check your own medicine cabinet. Pull out anything with PM in the name, anything labeled nighttime, and any allergy tablet, and read the active ingredient line. If diphenhydramine shows up more than you expected, that alone is worth a 5-minute conversation with your pharmacist this week. No appointment necessary. Number 8. Proton pump inhibitors. Number 8 is a medication your stomach loves and your brain may quietly pay a price for. Proton pump inhibitors, or PPIs, include big names like omeprazole, Prilosec, and esomeprazole, Nexium. They shut down acid production in the stomach and are handed out for heartburn, acid reflux, and that burning sensation after meals. People often stay on them for years, sometimes decades, because the moment they stop, symptoms tend to come roaring back. That rebound effect makes the medication feel indispensable, even when it may no longer be the right long-term choice. Here's the part rarely discussed at the pharmacy counter. Your stomach needs acid to properly absorb certain nutrients from food, chief among them vitamin B12, which protects the health of your nerves and brain. Suppress that acid for long enough, and B12 levels can quietly drop. Magnesium and calcium, both of which your brain cells depend on to fire and communicate cleanly, can decline as well. Starve neurons of these nutrients over time, and the result can be confusion and memory difficulties that closely resemble early cognitive decline, when the underlying cause may actually be a correctable nutrient deficiency. A large German study led by Willi Gahm and colleagues, published in JAMA Neurology in 2016, tracked more than 70,000 adults aged 75 and older. Regular PPI users showed a 44% higher risk of a dementia diagnosis compared with non-users. It's worth being balanced here. Later meta-analyses looking specifically at short-term PPI use haven't found the same association, and researchers are still debating how much of this link reflects direct harm versus other underlying factors in people who need long-term acid suppression in the first place. That nuance matters, but it doesn't erase the core practical concern. Long-term, high-dose PPI use deserves a regular look with your doctor. Here's the move. If you take a PPI every single day, that's worth a conversation. Many people can taper down to a gentler class of medication called H2 blockers, such as famotidine, Pepcid, which carries less of this concern. Some people also find relief through lifestyle measures like smaller meals, reducing late-night eating, avoiding lying down right after eating, and elevating the head of the bed a few inches. The goal is the lowest effective dose for the shortest necessary time, not a pill taken forever out of habit, and your doctor may also want to periodically check your B12, magnesium, and calcium levels if you've been on a PPI for several years, since a simple blood test can catch a deficiency long before it ever becomes a cognitive problem. It's also worth knowing that abruptly stopping a PPI after long-term use can trigger something called rebound acid hypersecretion, where the stomach temporarily overproduces acid, making symptoms feel worse for a week or two before settling down. This is exactly why any change here should be a gradual taper planned with your doctor, not a decision made alone on a bad night of heartburn. Number 7. Bladder antispasmodics. Number 7 is prescribed for a problem most people would rather not discuss out loud. Oxybutynin, sold as Ditropan, is given to seniors dealing with an overactive bladder, that sudden, urgent need to reach a bathroom that can reshape an entire day. The relief it provides is real, and so is the embarrassment it can spare people. But oxybutynin works by blocking acetylcholine, the same memory-related chemical that diphenhydramine blocks, and it crosses into the brain quite readily, settling right where new memories are formed. A widely cited 2015 study in JAMA Internal Medicine, the same Gray et al. Anticholinergic burden study referenced above, specifically flagged bladder antispasmodics like oxybutynin as among the more concerning anticholinergic drugs for long-term use in older adults, given how strongly and how consistently they block this pathway. What concerns me most clinically is how quietly this happens. Patients are told a pill will calm the bladder. Rarely is anyone told it might also be dimming their mental clarity over time. The resulting fog gets blamed on age, people describe forgetting appointments, misplacing keys repeatedly, or losing the thread of a simple conversation, and it's rarely traced back to the prescription until real cognitive ground has already been lost. If you take oxybutynin and have noticed memory changes, take that seriously. You don't have to choose between bladder control and brain health. Newer medications like mirabegron, Myrbetriq, work through a completely different pathway that doesn't block acetylcholine at all, and for many older adults, they provide similar bladder control with meaningfully less cognitive risk. This is worth raising at your next appointment. It's also worth knowing that bladder symptoms in older adults aren't always purely a bladder problem. Pelvic floor physical therapy, timed voiding schedules, and simple reductions in evening fluid and caffeine intake can meaningfully reduce urgency for many people, sometimes enough to lower the dose needed or avoid medication altogether. A urologist or pelvic floor specialist can often offer these options alongside or instead of a daily anticholinergic prescription. Number 6, statins. Number 6 might be the most surprising entry on this list because it's one of the most widely prescribed classes of drugs on Earth. Simvastatin, Zocor, and atorvastatin, Lipitor, are taken by tens of millions of people, especially after age 60, to lower cholesterol and reduce the risk of heart attack and stroke. Let me be clear from the outset, this is not an argument against statins. For most people with real cardiovascular risk, the heart protective benefits are well established and substantial. What often gets left out of the conversation is that cholesterol does far more than affect the heart. The brain is close to 60% fat by dry weight, and it uses cholesterol to help build myelin, the insulating sheath wrapped around nerve fibers that lets signals travel quickly and cleanly. The evidence connecting statins to memory problems is genuinely mixed, and I want to be honest with you about that rather than overstate it. In 2012, the FDA added a safety communication to statin labels, noting reports of memory loss and confusion associated with statin use, describing these effects as generally reversible after stopping the medication. Some observational studies have found associations between statin use and cognitive complaints, particularly with statins that cross more easily into brain tissue, such as simvastatin and lovastatin. At the same time, several large randomized trials have found no meaningful difference in cognitive performance between statin users and non-users, and some research even suggests statins may modestly lower dementia risk by protecting blood vessels in the brain. So here's the honest takeaway. Statins are not a proven cause of dementia, and this is absolutely not a reason to stop one that's protecting your heart. But if you started a statin and noticed new brain fog or memory changes shortly afterward, that's a real, worthwhile conversation with your doctor about dose, about switching to a statin that crosses less readily into the brain, such as pravastatin or rosuvastatin, or about whether the memory change has another explanation entirely. One practical tip many people don't know. If you do notice fog after starting a statin, it's worth timing it. The FDA's own reporting on this describes symptoms as generally showing up within the first weeks to months of starting or increasing a dose, and generally clearing up within weeks of stopping under medical guidance. If your memory changes started around a completely different time or crept in gradually over years, a statin may not be the real explanation at all, and it's worth looking elsewhere on this list, or beyond it, for the actual cause. Quick pause. If this is helping you connect some dots, take 1 second to tap the like button. It genuinely helps this information reach more seniors who need to hear it. And while you're there, let me know in the comments how many prescriptions you currently take. I read every single one. Now, back to the countdown. Number 5, benzodiazepines. Number 5 is the benzodiazepine family: lorazepam, Ativan, diazepam, Valium, and alprazolam, Xanax. These are among the most commonly prescribed medications in America for anxiety and sleep problems. They work by boosting GABA, the brain's natural calming signal that dampens an overactive nervous system. At first, they can feel like a rescue. The panic eases, racing thoughts slow, sleep finally comes. Over time, for some people, the picture changes. A well-known 2014 case control study by Bilioti Degage and colleagues, published in the BMJ, examined benzodiazepine exposure in nearly 9,000 older adults with Alzheimer's disease compared with matched controls, and found a meaningfully elevated risk associated with past benzodiazepine use, particularly with longer-acting formulations like diazepam. A subsequent systematic review of 6 studies found long-term benzodiazepine users carried roughly a 1.5 to 2-fold increased risk of dementia compared with never users. I want to be fair to the science here, though. This remains a genuinely debated area. Some researchers argue that anxiety, depression, and insomnia are themselves early symptoms of developing dementia, which could mean people are prescribed benzodiazepines because early dementia is already brewing, rather than the drug causing the decline. This is called reverse causation, and it's a real limitation of this kind of research that responsible scientists openly acknowledge. What's less debated is the day-to-day chemical sedation these medications produce. Learning slows, mental flexibility decreases, and many long-term users describe a kind of emotional flatness, as if they're moving through fog and no longer feel entirely like themselves. The exit from these medications also matters enormously. If a benzodiazepine is stopped abruptly after regular use, anxiety and insomnia can return with even greater intensity, sometimes accompanied by dangerous withdrawal symptoms. That makes the medication feel indispensable at precisely the moment it may be doing the most harm. So here is the rule, and it matters. If you've been taking a benzodiazepine regularly for more than a few weeks, never stop suddenly. Work closely with your doctor to taper gradually, often over weeks or months, sometimes with the dose reduced by only a small fraction every couple of weeks. Gentler alternatives exist for ongoing anxiety, such as buspirone, which doesn't cause the same sedation or cognitive clouding, and specialized forms of cognitive behavioral therapy for insomnia and anxiety can restore calm without the chemical cost. I also want to say this plainly because I think it matters more than any single statistic. If a benzodiazepine is genuinely helping you function, sleep, and enjoy your life, and your doctor has weighed the risks and benefits with you, that is a legitimate medical decision, not a failure. This video is meant to inform that conversation, not to frighten anyone into abruptly changing a medication that is currently working for them under proper supervision. Number 4, amitriptyline. Number 4 is a single medication prescribed for 3 completely different problems, and it carries one of the heaviest hidden burdens on this entire list. Amitriptyline, sold as Elavil, is an older generation antidepressant still widely prescribed today for nerve pain, sleep difficulties, and migraine prevention. That versatility is exactly why it remains so common. It looks like a medication that can do almost everything. Beneath the surface, though, amitriptyline is one of the most potent anticholinergic drugs still in routine use. It blocks acetylcholine so aggressively that with long-term use, memory difficulties move from being a rare side effect to something closer to an expected outcome in older patients. That same 2015 Gray et al. JAMA internal medicine study we referenced earlier specifically included tricyclic antidepressants like amitriptyline among the strong anticholinergics tracked, and found that people with the highest cumulative exposure to this class of drugs over roughly a decade carried a 54% greater risk of developing dementia. Many of these patients were simply prescribed the medication for sleep or nerve pain and were never told it could affect their thinking. They noticed words becoming harder to find, memory growing thinner, concentration weakening, and simply assumed it was part of getting older. It doesn't require a high dose. Even a small nightly amount, taken consistently for years, can quietly erode cognitive sharpness without any dramatic warning sign, until the cumulative loss becomes significant. If you or someone you love takes amitriptyline, this is worth a conversation soon. For nerve pain, options like duloxetine or gabapentin can offer similar relief with a much lower anticholinergic burden. For sleep, melatonin or a very low dose of doxepin, which is considerably gentler on this pathway at low doses, may serve as alternatives. For mood, newer antidepressants such as sertraline or escitalopram are generally considered far safer for long-term brain health. Number 3, paroxetine. Number 3 is the one I told you to watch for, because it's prescribed to millions of people for something that sounds completely harmless. Paroxetine, sold as Paxil, is one of the most widely prescribed members of a family of antidepressants known as SSRIs, used for both depression and anxiety. On the surface, it appears to be a modern, gentle option, far kinder than many older psychiatric medications. But here's the detail rarely discussed. Paroxetine is the one commonly used SSRI with meaningfully strong anticholinergic activity. That single characteristic sets it apart from close relatives like sertraline and escitalopram, and it means paroxetine taps into the same acetylcholine blocking pathway responsible for much of the concern on this entire list. Because of this, paroxetine appears on the American Geriatric Society's Beers criteria. a formal, widely used list of medications considered potentially inappropriate for older adults, specifically because of its anticholinergic burden and associated fall and cognitive risk in seniors. This isn't a fringe opinion. It's a mainstream clinical guideline that many geriatricians actively consult. There's a painful irony here. The medication is prescribed to help stabilize the mind, yet over time, in a population already vulnerable to anticholinergic effects, it may work against the very clarity it's meant to protect. The solution here is fairly straightforward. In older adults, paroxetine is generally considered a medication worth avoiding when alternatives exist. If you currently take it, this is worth raising with your doctor about switching to a different SSRI, such as sertraline or escitalopram, which carry a much lower anticholinergic footprint. Supporting healthy levels of B vitamins, particularly B12 and B6, may also help support mood alongside any medication changes your doctor recommends. Number 2. Antipsychotic medications. Number 2 is prescribed so quietly that many people taking it don't fully realize what class of medication it belongs to. This one concerns me deeply because many individuals never knowingly agreed to take an antipsychotic in the first place. The names include quetiapine, Seroquel, risperidone, Risperdal, and olanzapine, Zyprexa. These medications were developed and approved for serious psychiatric conditions such as schizophrenia and bipolar disorder. Today, however, they're frequently prescribed off-label to older adults for sleep problems, mild restlessness, or agitation associated with dementia itself. Powerful medications originally built for severe psychiatric illness, now sometimes used in homes and care facilities simply because a senior is confused, restless, or difficult for an overwhelmed caregiver to manage in the moment. The cost here is well documented and taken seriously at the highest levels of drug regulation. The FDA placed a black box warning, its strongest safety warning, on atypical antipsychotics in 2005, and extended it to conventional antipsychotics in 2008, specifically because of an increased risk of death in older adults with dementia-related psychosis. Beyond that mortality signal, these drugs work in part by suppressing dopamine, a chemical involved not only in mood, but also in focus, planning, and memory formation. Reduce dopamine activity enough, and the brain can become measurably slower and less responsive. Clinically, this is why some people on these medications appear dulled, emotionally flat, or almost absent, while families quietly grieve the gradual fading of someone who is still physically present. If you or a loved one is taking one of these medications, the first step is a direct question to the prescribing physician. Why was this started, and is it still truly necessary, or is it being continued mainly for convenience? Many behavioral symptoms in dementia can be improved without medication at all, through consistent daily routines, reduced noise and overstimulation, treatment of hidden pain, and better sleep and lighting management. When medication genuinely is required, the lowest effective dose for the shortest necessary duration is the safest path forward. Families are too often never told what these medications can do, and they watch a decline they assume is simply aging, when the true driver may be chemical. If a loved one is in a nursing home or assisted living facility and you suspect an antipsychotic has been started for convenience rather than genuine medical necessity, you're entitled to ask for the specific, documented reason in their care plan. Federal nursing home regulations actually require a documented clinical justification for these medications and periodic attempts to taper them when appropriate. Most families simply don't know to ask for that paperwork. Number 1. Anticholinergic polypharmacy. Now we arrive at number 1, and it isn't a single medication at all. It may be the biggest hidden driver behind nearly every story I've described today. Number 1 is anticholinergic polypharmacy, the danger almost nobody talks about, and possibly one of the most under-recognized contributors to medication-related cognitive decline in older adults. You were probably expecting one final, single, worst pill. The reality is more subtle, and in some ways more important than that. The greatest danger often comes from the slow accumulation of multiple anticholinergic medications taken together, while nobody ever calculates the combined or cumulative burden. Polypharmacy simply means taking many medications at once. Anticholinergic burden refers to the combined effect of all of those medications blocking the same memory-related chemical pathway simultaneously. Picture a very common scenario. A senior takes diphenhydramine nightly for sleep, oxybutynin daily for bladder control, and amitriptyline for nerve pain. Individually, each medication might produce only a small, barely noticeable effect. Together, those effects compound, and the total burden on the brain rises quickly. This is precisely the mechanism behind the landmark Gray et al. 2015 findings we've referenced throughout this video. It wasn't any single drug in isolation driving the strongest signal, it was cumulative, combined anticholinergic exposure across multiple medications and years that carried the highest risk. And in most of these cases, patients had no idea they were even taking anticholinergic medications because nobody had ever explained the concept to them, let alone shown them how their individual prescriptions added up. When acetylcholine is blocked from several directions simultaneously, the brain doesn't simply slow down uniformly. Neurons can weaken from chronic underuse, connections may shrink, and the overall picture on cognitive testing can closely resemble early Alzheimer's disease, even when the underlying cause is substantially medication-driven rather than neurodegenerative. Here is the hopeful part, and honestly, it's the reason I made this video. Medication-related cognitive decline is often at least partially reversible when it's caught early. Reduce the anticholinergic burden under proper medical supervision, and many people regain measurable clarity, energy, and memory within weeks to months. The aging brain is more resilient than most people realize, but only once the underlying source of harm is identified and addressed. The solution doesn't require anything dramatic. I'm Dr. James Revealio. Stay sharp, and I'll see you there.